ask the question, Dr. Cook, when you hear the word institutional narcissism, I mean, how would you describe that to us?
You know, it's a term that I had not heard until you arrived today. And I think that it's very appropriate. I think all institutions, and healthcare is no different, but I think all institutions like to think of themselves as representing something, whether it be a product or a service or healthcare or whatever the case may be. They would like to feel that they represent this product or service that everybody should want to have, because we do it better than anybody else. We make it better than anybody else. We have the most desirable product.
Yep.
And what happens here, and I'm really looking forward to where this conversation is going to go, is you can be easily distracted by the terminology that you apply to anything. And, you know, we've seen it with diseases, for example, and it certainly applies with respect to access to healthcare, I think. And what I'm getting at is it becomes very difficult to talk about something that nobody wants to be associated with. For example, if you use the term racism, nobody wants to get into that discussion. It's just too difficult. And for a while I thought, well, you know, that's kind of stupid, that we shouldn't be afraid to talk about that. But I think that that it's a valid idea that maybe we should talk about it in different terms, because I agree, Des, you mentioned earlier that you don't know any physician anywhere that would deny a person service because of their race. But patients get denied service day in and day out because of their economic circumstances.
Oh, for sure, Randy.
And the problem is that economic circumstances are tied to your race. So,
yeah,
Jay, I don't think I even came close to answering your question, but
you know,
maybe I've
along those
raised
lines,
another
Randy, a lot of these gray hairs that I have on my head now come from fighting insurance companies,
precisely
trying to be an advocate for my patients.
Yeah.
And you know, was regardless of color, is just whether, you know, is the insurance that they had, and that, you know, again, their socioeconomic status determines a lot at that time what their policy was. But you know, I don't think there's just one answer to this. This is I was
going to say that before somebody accuses me of trying to discount the inappropriate attitudes that are associated with this phenomenon, I do think that even among providers, there may be less enthusiasm for treating an economically disadvantaged patient, because there is automatically this assumption that they're not really going to try to take care of themselves.
Well, and that I've definitely seen, but you know,
but the truth is they would probably have, there's no question that they would be more likely to follow instructions and take care of themselves if they had the economic means to do so.
Let me ask you this: have you ever taken care of an indigent person?
I'm going to stop both of you right now, actually, because this Dr. Cook just really hit a nerve that is a good nerve. Hopefully, whoever's listening to
it's a good nerve.
It is a good nerve, because we all face this. I hope everyone would hear us out. Dr. Cook, you just said,
Randy, by the way, this is the lounge.
The lounge. Sorry, Randy. some physicians would actually tell a patient, I'm not going to take care of you until you take care of yourself first.
Yeah.
Right. And that patient could have 99% occlusion of the left main, or a subtotally occluded everything, and they're going to lose their leg in about 5 days. And I can go on, right? Situations like this. Are we, as physicians who know that a 99% left main or a fallen off leg, are we in a position to say to someone who is somewhat not in the right mind right now because they're in pain, they're not really there, go and stop smoking, or go stop doing this, or start taking your medicine, then I'll treat you. And next thing you know, that patient will die from VFib because of left main, or the limb is amputated because it's no longer there. And I love what Dr. Cook said, because that is such a thing that I hear here and there. And when I hear that story, the patient goes straight to be treated. Go ahead.
Yeah, it's almost, I've heard it too over the years too, Jay, like a doc, I'm not going to do surgery on that guy because he continues to smoke. It's like, that's a cop out, okay, to me. It's an opportunity to keep educating, and you're a healer. You're there to help guide your patient. You're not there to really pass judgment on them. You're supposed to be showing them, and if they fall off the wagon, you keep at it. And that even goes for somebody who maybe is indigent. We've all done pro bono work. I'm positive of that. We just do what we're supposed to do. We do what we're trained to do, and you let the chips fall. Whether it's somebody who can afford to pay their bill, I know I'm going to get some pushback on this, or not. It's a humanitarian thing. We're supposed to be. We took an oath.
We did, and I'm pretty sure all of us think that we're honoring that. And I guess the point that I was trying to make before is that we often get distracted from the problem that we should be looking at because we use such inflammatory words as racism and racial bias and things of that nature. And nobody wants to carry that label.
It's the scarlet letter of this time.
But the problem is being in an economically disadvantaged situation is unquestionably tied to your race and the neighborhood that you grew up in, and lots of other things. So it gets to be very difficult to separate those two phenomena.
So, and if I take you back in time, I have a paper that I published 7 years ago, actually, and a paper published recently. So actually, when Des was talking about racial disparity back then, we didn't have much actually to discuss. So we got together a bunch of guys, and then we wrote a paper. And at the time, what's interesting is that, we observed, we did a statistical model, and looked at the disparity of care between Hispanics, African Americans, and we found that there's a much higher poor outcomes between African Americans, about 55%, Hispanics in the 64% range. And you think in 7 years that would change, right? It's interesting to see that in 7 years it hasn't changed. And if you just give me one condition right now in cardiovascular disease, and I can give you the statistics back right away about what is the status quo today. So pick one. Pick some topics dear to your heart, like stroke, for instance, right? So if I ask you today, hey, Des, what do you think of stroke and the stroke outcome in patients who are African American, who are white, who are Hispanic, and the rate of stroke and the mortality associated with it? If I mention the numbers right now, it's going to be a little bit shocking, because the likelihood of an African American patient to get a stroke is about 50% versus white. But that is not really the main issue, but the adults, counterpart adults play. It's not even near 10%, but the scary part is the mortality rate from a stroke in African American patients is 70%.
Thank you so much for joining us for this discussion today. If you would like to learn more about our guests, head on over to our Patreon page where you can access exclusive content, including the full segment of our show. Never want to miss an Inside the Doctor's Lounge clip? Be sure to click the subscribe button to our MD Coach's YouTube channel. As always, we appreciate suggestions for future show topics. Let us know what you're thinking in the comments below. And finally, special thanks to Ryan Jones, who created and performs our theme music for the show.